Thank you, Sobhit. Basically, what I am going to talk in this presentation is how to go about what we should do. What can we do? We have had the 3, 4 presentation here, and my focus is on the cost. See, we are all for the patient, and if the patient pocket cannot allow, so we can't help. So that's why, if we have a kind of a protocol which can also make the patient comfortable and, of course, make us also comfortable. See, we have to understand what is our milieu, means what is our population. Patients, in the rural areas, they can't afford the treatment. They have to, reconcile to the fact that the affordability is not there, and it's difficult for them to carry out the treatment. You must have seen lots of these patients get lost in the follow-up, and that is because of the financial reasons. At the same time, we have to also see that the protocol which we are providing to the patient is also efficacious. We can't just focus on the cost factor. We have to see that it is efficacious also. And at the same time, it should be sustainable. Because AMD is a disease which, related to aging. So as long the patient lives, the disease will be there. And so is diabetic retinopathy. So we have to have some kind of treatment protocol which is sustainable. And of course, as I told you, that my focus on the economics, that the patient should be able to afford. If the patient is not able to afford, what is the use of the treatment, or what is the use of the new drug? So how should we go about? I think we should examine the efficacy of all the anti-VEGF. That was the reason why I had all these presentations. We had a presentation on aflibercept, we had a presentation on Avastin, we had a presentation on Razumab, to make you understand what is the efficacy of these drugs. So that's very important. And then look into the cost factor. I'll just show you, I have 2 PowerPoints in which I'll show you what is the cost factor which is involved. And then the other thing is, look for the compliance. We talk of treat and extend, we talk of PRN, we talk of this monthly treatment. So, but then the compliance of the patient has to be there. You want that the patient should come to you at the desired follow-up time, and at the same time, you also want that patient should not lose his vision because of some injections which is missing. So in fact, I have put a question to the panel related to this, that would you like to fix your mind on a particular regime of treatment, or you would like to customize it according to the need of the patient? So that is another thing. And then, of course, the ease of follow-up we have to see. So if you want to, I think Sobhit and Bhuvan and all those speakers who were here, I think Girdhar is not here. I want to, Girdhar is here, yes. So I want to devise a protocol of different arms. I'll give you 2 PowerPoint presentations showing what is the cost involved. Can we combine, like aflibercept with this eccentrics as just now I had a talk with, I was talking to Sobhit, and he said that after say 10 injections or after say 4 injections of aflibercept, the guy gets fed up because he has too much of money he has to shed out of his pocket. So can he continue on the eccentrics, or for that matter on Avastin? So we need to have these arms. And then what is the arm cost? If suppose in AMD we have 9 injections, and if 9 injections with aflibercept, what is the cost? 9 injections with this eccentrics, what is the cost? And if we combine, then what is the cost? So define the cost of the different arms. And then we will make a multicentric large cohort and long duration trial to conduct field trial. Why I'm saying this? Because to make any clinical trial effective, all these are the basic parameters. It should be multicentric, it should be large cohort, and it should be long duration. By large cohort, I don't mean 10,000 because that will not be possible. But at least 100 patients, maybe at least 500 patients. So that is important. We know that eccentrics, early gain is by eccentrics. So you can see here that 3 months, 18% improvement in the vision is there. If it is 15 letter and 10 letter gain is 37%. And until 3 years, this is sustained. So initial gain is by eccentrics. Now let's see the logistics. This is the logistics you can see here as far as the cost is involved. The safety of these drugs, you know, they are all safe. Biosimilar, we don't have enough data about the efficacy of the bevacizumab biosimilar. But I believe all these biosimilar, all this bevacizumab, the eccentrics, aflibercept, and this bevacizumab or Avastin, they all have been efficacious. And see this, you know, if we see the cost, per injection, this is the cost of all these drugs. And of course, this is the patient, you know, support program, which is only available with this eccentrics at this point of time. But the other drugs are there, you know, and this is the average cost. I'm talking of the average cost. Some, you know, centers may be, you know, charging 60 or 65. Some centers here may be charging 30,000. But that is the average cost which is in the hospitals. Now this I have computed for you if we have a combo treatment. This is just to give you an idea about the different arms. What could be the different arms? And I'm talking of 9 injections in a year. If we have a 9 inject, this is the, you know, the cost of the treatment does not include just the injection cost. It includes the cost of the procedure, includes the diagnostic per year for at 9 visits, and then diabetic and other medication if patient is a diabetic, and retinal treatment cost per year, the cost of the laser if it is needed, and the consultant fees. And altogether, you can see if it is only eccentrics, this comes to around somewhere around 2,66,200. If it is eccentrics with bevacizumab, if we combine the two, means 3 injections with for early gain and 6 injections for maintenance. If we do that, the cost will come down to 1,62,000. And then if it is eccentrics with biosimilar, means if razumab is there with eccentrics, then the cost will be somewhere around 2,21,000. And you must be wondering why it is more, because eccentrics has got a, you know, the program, patient support program. So that is the one advantage with the eccentrics. And then if you see here, the ranibizumab biosimilar, like razumab, it comes around 1,95,200. But this is the cost. By the cost, I cannot, you know, tell you that with 9 injections, we will get the same effect what we will get with a one monotherapy of with one drug, without combination. So for that, we need to have a trial. So what do we see? We see here that anti-VEGF is, of course, the mainstay of treatment. And the anti-VEGF was started somewhere around 2006, 2007. We all used, before that, there was no anti-VEGF. We were only doing PDT, right, left, and center. And then the most important thing is the safety concern. We have the safety concern for most of the drugs right at this point of time, but we do not have for the newer drugs, biosimilars, which are coming in the market. And then you know, the main problem is with the cost, because if you know, give aflibercept to a patient for a long time, say 9 injections, it's very difficult, and similarly is for the eccentrics. So the cost of treatment is the main reason, you know, for which the patient withholds himself. Many patients says, "Abhi paisa nahi hai mere paas mein, hum abhi jayenge, 6 hafte ke baad aayenge, 8 hafte ke baad aayenge," and he can't come to the follow-up. So that's a very, you know, prohibiting factor. And then, of course, it's very important to see the patient compliance, whether he can come or not, because he's coming from a far distance. So we have to make allowance for that. That's what I say, that rather than talking of you know, PRN treatment, monthly treatment, or, you know, for that matter, treat and extend treatment, we should customize it according to the need of the patient, because that's very important. So I suggest, I think Girdhar is here and Sobit is here, myself and some other people, we can join together and have a kind of a multi-centric trial. And, we can have eccentric three. This is just a, suggestion. We can have 3 aflibercept also, depending upon what kind of disease is there. If PCV is there, we can of course start with aflibercept. But if the non-PCV AMD is there, we can use eccentric injections. So, and then we can sustain it with, Razumab or Bevacizumab or any other biosimilar injections. The basic idea is to see the cost of the 9 injections. At the same time, we have to see that the drug is, the combined drug, the combination of drug is effective for the patient. So this is just a suggestion, and we'll, sit together and we'll see how we can work on this. Thank you very much for kind attention.